My name is Matt, and for my honors project, initially I was going to discuss various stages of labor, different issues that happen within those stages, and the treatment interventions we employ as clinicians to address those issues. So I did that, and I also added some additional, hopefully, high yield labor content, such as pelvic shapes, and also some different diameter measurements we use to sort of classify or characterize the pelvic inlet, the mid pelvis, and the pelvic outlet. Um, and lastly, there's a couple slides at the end with just some miscellaneous, again, hopefully high yield shelf content that I would feel great if it scored you one or two additional points on the exam. So do as you occiput. Occiput anterior is the presentation that we are looking for. So what is protraction versus arrest in the active phase of stage one? I don't love this active phase of labor overlying label here because protraction is more specific to the latent phase. So the latent phase is 0 centimeters of cervical dilation up until 6 centimeters of cervical dilation. And then once we reach 6, we're in the active phase of stage one. So protraction of this first phase, this latent phase, is defined as greater than 20 hours to get from 0 to 6 in a nulliparous patient, or greater than 14 hours in a multiparous patient. And naturally it follows that the treatment would be oxytocin to increase the strength of those uterine contractions, get some pressure from the fetus on the cervix, and get to that 6 centimeters of dilation that we're looking for. And next, the arrest in the active phase of stage one, also known as the secondary arrest of dilation. The goal here is to try to progress from 6 centimeters to 10 centimeters, at which point we're in stage 2 of labor. But leaning into the nomenclature, arrest, like stopping, no further cervical change. It's in hours, so that's greater than or equal to 4 hours with adequate contractions, meaning greater than or equal to 200 Montevideo units over a period of 10 minutes, or greater than or equal to 6 hours with inadequate contractions. And so we measure the strength of uterine contractions with the intrauterine pressure catheter, which just placing that in the first place requires that the membranes are ruptured. But say, like here, when we just say greater than 5 hours, I don't think they're necessarily tracking the strength of contractions. We can go ahead and do an amniotomy or a manual rupture of mom's membranes and further augment with oxytocin to try to boost the strength of the contractions and get the fetus pressing on the cervix so that we get to the 10 centimeters, the full cervical dilation, so we can go into the second stage. So one quick aside, UWorld lists the cesarean delivery as the treatment for the arrest in the active phase of stage one, otherwise known as the secondary arrest of dilation. That's a true statement. It's kind of like a qualified true statement though, because we obviously, like, we know this is going on, which is referenced up here. No further cervical change in 4 hours with adequate contractions, or let's say 5 or 6 hours with inadequate contractions. Go ahead and give oxytocin. Still, we're not seeing any cervical change, not making any progress. The caveat is that we need the fetal station to also be a negative value. So fetal station is the relationship between the presenting part of the fetus and the ischial spines. And so if the presenting part of the fetus is 1 centimeter above, that would be a value of -1 for fetal station. And so we go -1, -2, -3, -4, -5, and then we're all the way to the uterus. And then +1, +2, +3, +4, +5, and then we're all the way to the vagina on the other side. So yeah, if we have a negative fetal station, we got secondary arrested dilation, then we are definitely trending towards the cesarean delivery as this table suggests. Okay, this is just some more visual representations of the stages of labor. Got a table here with all the things I just mentioned. Here we're discussing the protraction of the latent phase, trying to get from 0 to 6. Greater than 20 hours, again, some review for nulliparous women, or greater than 14 hours for multiparous. And then, as I just touched upon with active phase, we also have some very specific, I guess you could call them like rates of cervical change that we expect to meet, or else we will. It's just considered like within the active phase once we're at 6 centimeters. It's not necessarily a rest if we're still moving, because we're not at a standstill, but we're just not progressing at the rate that we'd like to. So basically, the threshold that we look for is 1.2 centimeters per hour in a nulliparous patient, or 1.5 centimeters per hour in a multiparous patient. So those are good numbers to have in the back of your mind. And lastly, this diagram here, very similar to this one. I like it a lot though, because it just adds sort of the thought process and some of the treatment strategies for these different issues. So, circling back to the protraction of the latent phase, we got engagement of the fetal head, first cardinal movement of labor, when the widest part of the fetal head from ear tip to ear tip is at the level of the pelvic inlet. And it lists all of the things we can sort of do to address this. We can insert a balloon catheter, blow up the balloon to increase the pressure within the uterine cavity. We can do an amniotomy, just manual rupture of membranes. Oxytocin, as we discussed in the last slide, and also misoprostol, the PGE1 analog that not only ripens the cervix, but also induces uterine contractions as well. So once we get that 6 centimeters, eventually we're in the active phase with this really nice star I drew myself. And I got some symbols here. So no cervical change in 4 hours with adequate contractions. Again, greater than or equal to 200 Montevideo units over a 10-minute period. Taking the peak of each contraction and like sort of the base, and subtracting those values and then summing those across the 10-minute period. Want to get to a total of 200 to be adequate. Or we're at greater than 5 hours or 6 hours with inadequate inadequate uterine contractions. We're going to go ahead and give oxytocin, and if we're still not getting where we need to go, if we're still arrested, and we have a negative fetal station value, then at that point it is looking like a C-section is imminent. As far as stage 2 and beyond, I will get to this in a slide very soon. I do want to briefly touch on stage 3. So that is basically the delivery of the placenta. So stage 3, if it takes more than 30 minutes for us to deliver the placenta, that is considered a protraction of stage 3 of labor. So basically, the strategies that we do, what we learned over these last few weeks in this clerkship. You apply the suprapubic pressure. You do the careful downward traction with the clamps on the umbilical cord, and you just want to make sure that it's coming out at a steady rate, and you're not feeling that. It's hard to describe the sensation, but it basically feels like it's coming out at a steady rate, and all of a sudden, like instead of pulling out one loop at a time, you're pulling out 3 to 4, like you're dragging like an extra bit out. Just want to be very, very cautious of pulling too hard and potentially inducing a placental inversion. That is the definition of a elongated or retained placenta. when we have more than 30 minutes pass and we're still not able to deliver the placenta effectively. And just some questions down here. Determine the progression through the second stage of labor. Mentioned that already is the fetal station. And how do obstetricians measure this? It is with a digital cervical exam or like physical palpation with your fingers to sort of negotiate the relationship between the presenting part of the fetus and the ischial spines. And one thing I forgot to mention here in stage 3, you can go in and do a manual extraction if necessary, if that 30 minutes has passed and you're still not able to deliver the placenta. Okay, so this is just a brief aside that I wanted to touch on, just because I found it in a NBME practice test explanation. So, typically an overwhelming majority of the sources that I've seen define, the active phase of stage 1 beginning at 6 centimeters of cervical dilation. That's the value that I'm sure we all know and feel comfortable with. But here it very clearly says the active stage begins after 4 centimeters of cervical dilation. And that's a value I saw in some other online resources, as well as an Anki deck that wasn't the Young-King deck. But this is obviously a very important source because they write the shelf exams as just something to be aware of. Okay, so back to our second stage, which begins at 10 centimeters of cervical dilation, maximally dilated. The definition of the second stage arrest of labor, not arrest of dilation, because we're already maximally dilated, is insufficient fetal descent after pushing 4. All of these values here match up over here, so greater than or equal to 3 hours if nulliparous, and that is without an epidural, or greater than or equal to 2 hours if multiparous without an epidural. And you just tack on an extra hour with the presence of an epidural. Oh, excuse me. Okay, so the most common cause of this second stage arrest of labor is cephalopelvic disproportion secondary to fetal malposition. And so I'll get into the nitty gritty of all the different fetal malpositions later on. But as we know, there's transverse lie, which often self-resolves. There is a variety of breech presentations, one example being frank. There's mentum posterior, where the baby's chin is sort of facing mom's back. There's just a lot of different things that can go on in terms of the fetal positioning that complicate the labor process. So as far as like the treatment here for the second stage arrest of labor, medically our options are kind of limited. What obstetricians tend to do is an operative vaginal delivery, which can include a forceps assisted or a vacuum assisted vaginal delivery, or alternatively a cesarean delivery. So some other risk factors: excessive weight gain during pregnancy, maternal obesity, diabetes mellitus. I want to say maternal obesity is a risk factor for second stage arrest, and also issues in the first stage of labor as well. And inadequate contractions, so hypotonic contractions, that is the most common cause of a protraction of the latent phase of labor, as we discussed here. Okay. Okay. So moving on to the three P's, which I'm sure you've heard about by this point: power, passage, and passenger. This particular slide is related to the passage, so the different pelvic shapes that clinicians encounter: gynecoid, android, little android logo, anthropoid, and this is always a mouthful, platypoloid. So as far as ideal pelvic shapes, the gynecoid is usually leads to smoother vaginal deliveries and less complications. So pelvic inlet, entrance to the birth canal, nice round entrance to the birth canal, and is conducive to a successful spontaneous vaginal delivery. Android, it's heart-shaped, which is lovely, but it's a little bit more narrow in the pelvic inlet. So this can cause problems, make it harder for the baby to progress through the canal, oftentimes resulting in cesarean sections. And anthropoid, as you can see, slightly more narrow than this like big round heart-shaped gynecoid. It is, it's possible. It's not the, it's not the worst pelvic shape. It is possible to have vaginal deliveries, but they tend to have longer labor than those with the more ideal gynecoid pelvises. And here at the bottom, you can see positional change throughout labor may help when patients have this pelvic shape. And lastly, hardest to say and also hardest to deal with, platypoloid. Vaginal childbirth, extremely difficult. C-section, more often than not with platypoloid, will be the outcome. So a couple of questions that will be answered several slides from now, but I'll go ahead and just give you brief answers so you're not thinking about it. 36 weeks, can you still do external cephalic version, which is where you sort of manually reposition the fetus in order to promote a more optimal presentation? And the answer is yes. You can even do it beyond 36 weeks. It is usually not performed, external cephalic version, when in labor, because the uterus is harder due to contractions. There's a lot more motion, and for a similar reason, it's less likely to be permanently effective because of all the motion and commotion. And so even if you are able to manipulate the fetus into a more ideal presentation, there's still a chance that they could spontaneously, revert back into a presentation that is suboptimal. Okay, so here's just that same picture of the different shapes, the pelvic inlet. And as you progress through the birth canal, pelvic inlet, and then mid-pelvis, which is indicated by the interspinous distance, or the distance between the ischial spines. Also the metric or the reference point for fetal station, and then lastly the pelvic outlet. And as you'll see on the next slide, the indicator for the diameter of the pelvic outlet is the distance between the ischial tuberosities, which everyone finally remembers. Wiki teaching us in anatomy is what we actually sit on. Brief definition for the intraspinous diameter. It's usually between 9.5 and 11.5 centimeters. It is the limiting factor in the mid-pelvis. This transverse, we say intraspinous diameter, the two spines, interspinous between. It is the smallest diameter of the pelvis, but ideally it is still greater than 10 centimeters. And here's just some more images. So we just discussed the intraspinous diameter within the mid-pelvis. The conjugate diameter. Okay, so first of all, B here. This is the intraspinous diameter between the ischial spines. The conjugate diameter is usually between 10 and 12 centimeters, and you can think of this like an AP or anteroposterior diameter. So here at the pubic symphysis is where we start. This X, dotted line, labeled A, and then here's the second X here posteriorly. So it is also known as the Baudelokes diameter, in case you get a test question writer who is just feeling pretty angry and wants to be mean. It's also the Baudelokes diameter. So the external obstetric conjugate corresponds to the true internal conjugate. Outer edge of the upper edge of the pubis and the posterior external point at the first sacral spinal segment. And I believe Wiki also said to assume always assume four fused sacral vertebrae. So here to here, AP diameter or conjugate diameter or Baudelokes diameter. And that's also shown here. And the intertuberous, as I touched on in the previous slide, also between 10 and 12. This is the transverse diameter of the pelvic outlet, so the last sort of space that the fetus will pass through prior to delivery. And it's the lower internal margins of the ischial tuberosities detected most caudally and medially. So, moving right along, this is sort of circling back to cephalopelvic disproportion secondary to fetal malposition, and how this is the most common cause. We talked about it right here. This is actually the most common cause of the arrest of the second stage of labor, the cephalopelvic disproportion secondary to malposition. So this should say arrest, my apologies, as it says up here. And so, this is just like the same image that we've seen before. We're pushing for 3 hours in nulliparous or 2 hours in multiparous. And just like not making meaningful fetal descent or any progress in that regard. We can go ahead and give oxytocin, but at the end of the day, it's more than likely with a negative fetal station, it's going to be an operative C-section or a positive fetal station past the ischial spines of the presenting part, perhaps a forceps or vacuum-assisted vaginal delivery. And once we get to the end of start stage 2 with this 10 centimeters dilation, once you get to the end, delivery of the fetus. And then the end of stage 3, as discussed earlier, is hopefully within 30 minutes, the delivery of the placenta. Okay, so driving home the point of fetal station and its importance in the second stage of the labor. I have multiple diagrams here. Like about this one is it sort of gives the upper and lower bound of sort of when we stop the fetal station measurement, plus 5 centimeters the vaginal opening and minus 5 centimeters at the uterus. So the significance of the +2 station. I remember having a conversation with a resident in clinic, and we were discussing how in order for a vacuum-assisted vaginal delivery to proceed safely, we need to be at a +2 fetal station, or else it's contraindicated and not sort of the best thing to do to safely deliver the fetus. And at that point, we'd probably look towards something like a cesarean delivery. So, getting into more of the details here. Apologies for the text-heavy slide, but this was sort of important to tease out the specifications, mostly related to vacuum-assisted vaginal delivery, although we have some criteria for forceps here and here. So starting with the prereqs for an operative vaginal delivery, also applying to both vacuum and forceps. Obviously, full cervical dilation at 10 centimeters. You need to be in the second stage of labor to be considering these sort of interventions. And that is also mentioned here. Cervical Oz at 10 centimeters for both forceps and vacuum. And does not necessarily need to be at 10 centimeters, or is not at 10 centimeters for a cesarean section. It actually is not at 10 centimeters for that. So we also have previously ruptured membranes because we are engaging the fetus with either a pair of forceps or a suctioning device in the vacuum. And so obviously we need our membranes ruptured prior to doing this. Engagement of the fetal head. So the first cardinal movement of labor needs to be, needs to have happened. So this is when the widest part of the fetus's head from ear tip to ear tip is at the level of the pelvic inlet. And so also the clinician has determined the position of the fetal head, so there are no surprises in terms of cephalopelvic disproportion secondary to fetal malposition. Fetal weight estimation is also an important part of this process. As a macrosomic infant could prove, or would almost certainly prove to be a much more difficult undertaking in terms of providing the necessary traction and rotation in order to extract the infant from the birth canal. We also have some considerations of the pelvis. We talked about the four kinds of maternal pelvises, so we've thought about that as well. We have adequate anesthesia, obviously, for pain management. Epidural often is used, and empty bladder, so we don't have any perforations. Obviously, consent is signed, and we have a contingency plan in the instance of failure, which I don't have exact data for you, but it does occur. It is not like a freak occurrence for a forceps or vacuum assisted vaginal delivery to not be effective in delivering the fetus. And at that point, we usually proceed almost always to a cesarean delivery. I actually can't really think of another delivery method you would be able to use in the instance of a failed operative assisted. So moving right along, I'm going to start here with the ACOG's classification of the mid forceps, which we have here for the operative. All of this, and this is from this paper, that is all operative specific content, which we will get to. So the mid forceps delivery performed when the fetal head is between stations 0 and +2. So we don't get a lower bound for fetal station here for the mid delivery for the vacuum assisted vaginal delivery, but we do have it here for the forceps. So if we're between 0 and +2, but not including +2, and that would be the mid forceps. And then the low forceps, which the correlation is here for the vacuum, that is defined by fetal head position at a station of +2 or lower. So 0, basically right up to +2 is mid, and then +2 or lower, including +2, is the low forceps delivery. And interestingly, we have the threshold, or I guess the lower bound for performing forceps and vacuum-assisted vaginal deliveries here in this table is at actually +1, which is obviously 1 centimeter lower than the criteria mentioned here by ACOG. But I would imagine, I'm going to probably go with ACOG on this one. You can perform even if you're at 0 station, you can perform a forceps assisted vaginal delivery. The other reason why I'm kind of doubting this table a little bit is they have cephalohematoma as a side effect for forceps, which is more commonly associated with vacuum, at least according to my knowledge. Other side effects, while we're sort of discussing that, facial nerve injury is associated with forceps. Think of the two Fs. And then brachial plexus injury is more often associated with vacuum-assisted vaginal delivery. Um, uh, Lacerations, vaginal lacerations, often associated with forceps. But as we can see here, these are complications specifically for the vacuum-assisted vaginal delivery. So we have the extension of vaginal lacerations, sphincter and vaginal pain for mom, and scalp lacerations, cephalohematoma, like I mentioned, more commonly associated with the vacuum-assisted intracranial hemorrhage due to the suction force, retinal hemorrhage, hyperbilirubinemia, and neurological injury. So it does look like the rate of intracranial hemorrhage is 1 in 650 to 850, which is fairly low, but it is still worth mentioning. So before we get to the classifications of the vacuum-assisted vaginal deliveries, just want to talk about some brief contraindications. Discouraged before 34 weeks gestation. Want to make sure we're meeting all these prereqs very carefully prior to initiating these procedures. And then also certain fetal conditions like von Willebrand's disease, hemophilia, etc., osteogenesis imperfecta, preclude the use of a vacuum to expedite delivery. So one other point, when you have more than 2 or 3 pop-offs or attempts, meaning the vacuum had been applied to the fetus's scalp, and then in the process of attempting to pull the fetus through the birth canal, that it actually popped off. That is sort of the threshold for proceeding with cesarean section and kind of giving up on the vacuum assisted. And lastly, the classifications of the vacuum assisted deliveries. So similar to the forceps, with the mid, start at the bottom. This is when we're above +2 station, though no lower bound is given or was given in the study. However, we do have head engagement. So that first cardinal movement of labor, again, the widest part of the fetal head, ear tip to ear tip, is at or within the pelvic inlet. And then low delivery, which we have to find here for forceps. This is when we're at station +2 or more, but we're not on the pelvic floor. And in these low deliveries, we have an additional criteria. You can have without rotation, so we 45 degrees or less, similar to the outlet delivery, which is always less than 45 degrees. And then you can't have with rotation when it is greater than 45 degrees, meaning some more significant turning of the device and the fetus was necessary to progress through the canal. And lastly, outlet. So don't need much rotation. The fetal head is at or on the perineum. Fetal skull has reached the pelvic floor. Things are looking pretty good here for a relatively easy vacuum-assisted vaginal delivery. Scalp is visible at the introitus, no separation of labia. And lastly, we have the sagittal suture in an anterior-posterior, right occiput anterior, or left occiput anterior, or occiput posterior position. And as we touched on with all these different delivery types, for the vacuum assisted, it depends on the status of the fetal head at the time of application, which I would imagine is the first application, when you have instances where pop-offs or when the vacuum comes off the fetal head, and then also the degree of rotation necessary to extract the fetus. Okay, so optimal positioning. Do as you occiput So occiput anterior, this is sort of the gold standard, also known as vertex anterior. You can see occiput here, pubic symphysis, so we know this is anterior, this is posterior. And you can also have right occiput anterior, left occiput anterior, as you mentioned on the previous slide. And then, again, this is all relative to the maternal pelvis. So because the occiput is facing the left side of the pelvis, this would be left occiput anterior. So just make sure that you're mindful that it's always relative to the maternal pelvis. And some other positionings here. This is called sunny side up, vertex occiput posterior. So we have the occiput here, and that's facing mom's posterior. And it's not the worst thing in the world. You can't have a spontaneous vaginal delivery in this position, but it tends to be a slower, longer process. And back labor, because we have sort of the hard part of the fetus, the spine, and the back of the head, scalp. That is basically pressing against mom's back, and can result in quote-unquote back labor. And vertex anterior, head down, occiput anterior. It's the best position for delivery because you get that direct pressure on the cervix from baby's head, and it's also resulting in direct encouragement to dilate and efface and progress through the stages of labor. So, what can we do in situations where we are not so lucky as to have an occiput anterior presentation? So these are a variety of breech presentation types. Frank is the most common type of breech presentation. I love this diagram, by the way. I think it's obviously breech presentations are no joke, not something to be made fun of by any means, but I just think the diagram is really they did a good job with it. So external cephalic version can definitely be performed at 36 weeks or beyond. That was in reference to these questions here. So can you still do ECV 36 weeks? And when you usually not perform ECV, or when is it less likely to be permanently effective? So as I touched on earlier, when we're in labor and the placenta, or the uterus is contracting and harder than normal, it's just really not as easy to manually reposition the fetus when you are pushing against a highly mobile and contracting placenta. So that is why we typically, or obstetricians typically, do not perform ECV once we're in labor. The contraindications for external cephalic version, any indications for cesarean delivery, like regardless of the fetal position, like non-reassuring fetal status, failure to progress during labor, these are situations where we probably proceed with, or almost certainly proceed with, a cesarean delivery. Placental abnormalities, previa or abruption. So if you have a previa and you try to maneuver the fetus or do an ECV, there is potential for a premature rupture of membranes, which is not a good thing. And then also placental abruption, when you have the placenta it's basically been removed partially from its attachment in the endometrium. Both of these situations are times when we avoid the ECV. Oligohydramnios as well. If you have low amniotic fluid, unlikely to perform an ECV. ruptured membranes, hyperextended fetal head, multiple gestation, or any fetal or uterine anomalies. So now that we've addressed the contraindications, as far as the risks that are associated with ECV, so there is a risk of placental abruption, there's a risk of umbilical cord prolapse, and there's also a risk, oh man, what is the third one? Abruption, prolapse, and preterm labor. Those are the three risks that I know to be associated with, premature rupture of membranes. Risks associated with externally or manually repositioning the fetus when we have various breech presentations. As I'm sure you're all aware, we typically, when it comes to transverse lie, which often spontaneously resolves by itself without any intervention by a provider, that is one sort of non-ideal fetal presentation that is typically not interfered with, again, because it commonly resolves by itself. And so at the bottom left here, apologies for taking this directly from Anki, but I thought this was helpful for me in terms of identifying risk factors for breech presentation. So you can sort of categorize it by limited fetal movement. Up here, the oligohydramnios or fibroids, intracavitary fibroids or submucosal fibroids that are limiting fetal movement and resulting in breech, suboptimal presentations. On the other hand, you can have breech presentations because of excessive fetal movement. So if you have too much amniotic fluid and babies, swimming around in this big old pool, that is another situation where, with all the excessive movement, that breech presentation becomes more likely, and also fetal growth restriction. So when the fetus is not growing properly and not filling the uterine cavity in a way, like in a normal way, I guess you could say, or like an adequate way, that increases the risk for abnormal presentation. Okay, so moving right along here, stage 3 of labor. And the most common cause of postpartum hemorrhage, as I'm sure we're all aware, the uterine atony. I digress. So as far as things we can do for postpartum hemorrhage, which is the greater than 1,000 milliliters or cc's of blood loss, either after a vaginal or a C-section, usually the first intervention is the oxytocin. Just max out the oxytocin and bimanual massage the uterus to induce contractions and hopefully provide some hemostasis so that we can avoid hemodynamic instability in mom and just pretty much stop the blood loss. Other things we can do if we're not making any progress with oxytocin bimanual massage, uterotonics. So methyl or gonavine is something that is widely available and fairly cheap and often a first choice. Granted, that is if the mom does not have hypertension, because beyond causing uterine contractions, it also causes vasoconstriction, which we all know can worsen hypertension. I do believe it's also contraindicated in cardiovascular disease as well. Carboprost, good old PGF2 alpha, is another uterotonic that is often used and induces smooth muscle contraction and spasm of the uterus in an effort to sort of halt the bleeding. And so this is contraindicated in asthmatics, obviously because bronchospasm would directly worsen an asthmatic symptoms And in pregnancy, asthma can go feels like many different ways. Sometimes it improves, sometimes it doesn't. So we want to make sure that we're not providing medical interventions or drugs that would directly be responsible for worsening a patient's asthma. Kind of a cheesy memory hook, but PGF2 alpha, like if you say F2, like F2, like kind of like a chew. I don't know. It just helps me remember asthma and bronchospasm. But yeah, I guess now that's more about like allergies, and so it really doesn't even make sense. So we can just pretty much scratch that from from this presentation. Lastly, we have a V-Lynch compression suture. So if mom is bleeding out so much that we need to do an exploratory laparotomy or a diagnostic laparotomy, diagnostic laparoscopy, probably wouldn't be open, but it could be if she was really unstable from a hemodynamic perspective. The V-Lynch compression suture, using these steps here in this diagram, basically is like a manual way, without using your hands directly, a manual way to induce uterine contractions and hopefully stop that bleeding that has proven to be has resisted all the other medical interventions. Okay, almost there. A couple high yield buzz phrases or word associations that I just thought would be kind of fun to have at the very end. So when you're in labor, you have a sudden loss of fetal station. We are thinking about uterine rupture. In stage 2 of labor, progressing well, and all of a sudden we have the retraction of the fetal head into the perineum. This is known as the turtle sign, and it is often associated, or pretty much always associated, with a shoulder dystocia. And we have a sudden vaginal gush of blood, cord lengthening, and a uterine fundal rebound. This again is the uterine rupture. Did it twice in the first 3, just to confuse you. But yeah, if you see that uterine fundal rebound, and you get that gush of blood, all of a sudden the cord's longer than you're expecting, that is pretty indicative of a uterine wall rupture. Rope-like mass extending from the lateral abdomen to the uterus 1 week post-delivery. So this would be a case of ovarian vein thrombophlebitis. Cephalohematoma, I included this again because we're thinking about a vacuum-assisted vaginal delivery. And postpartum hemorrhage with a non-palpable uterus. This would more than likely be a uterine inversion. So if you're a med student, I actually almost did this and I got stopped by Dr. Gonzalez in my tracks. If you're putting too much traction on the cord after delivery, when trying to deliver the placenta, you can, if you really, really overdo it, you can actually invert the uterus and basically pull it inside out, which is a surgical emergency. Patient's going straight to the OR, and it would be associated with quite a bit of blood loss. Lastly, villus lakes within the placenta. We're thinking placenta accreta. Yep, accreta. I have a nice picture here. These villus lakes going from the bottom up. So postpartum hemorrhage, non-palpable uterus, uterine inversion, cephalohematoma, vacuum-assisted vaginal delivery, touching on the facial nerve injury associated with forceps, and the brachial plexus, again associated with the vacuum-assisted, and then rope-like mass, ovarian septic vein thrombophlebitis. And let's see, sudden vaginal gush, cord lengthening. That fundal rebound is a very good buzz phrase for uterine rupture. So if you're progressing through labor, and then all of a sudden, the fundus is like returning to a height that it really shouldn't be at. That is indicative of a uterine wall rupture. Stage 2, progressing, retraction of the fetal head in the perineum, shoulder gets stuck, turtle sign, and then sudden loss of fetal station. Again, uterine rupture when you have, a discontinuity in the muscular wall of something like the uterus. It's the contractile force that it's going to be able to produce is just simply not going to be the same. Okay, this is my last slide. Hopefully get through it pretty quick. So for some reason, I have consistently missed a lot of questions on ulcers. And I just think, it's very, very likely we'll see at least 2 or 3 on the shelf. So it's always good to review because, a lot of the details seem to just sound very similar and overlap. So I find it really helpful to separate them into painful and painless. So painful, we have herpes simplex virus, typically HSV2 in the genital region, and then Haemophilus ducreyi, which produces the chancroid. So painful that you cry. Everyone remembers that from bio or micro last year. And the painless ulcerations are primary syphilis, the chancre, it's also called donovaniasis, which is kind of confusing with Leishmania donovani, but I digress. Granuloma inguinal, caused by Klebsiella granulomatis, and Chlamydia trachomatis cerevirus L1 through L3, which we all know is lymphogranuloma venereum. So once you have this sort of scheme of painful versus painless, then you can kind of work your way down and use some buzz phrases to eventually get to hopefully the right answer. So for painful, if you have like some description of like both vesicles and ulcers, so the ulcers usually result from the vesicles rupturing on an erythematous base, and they're painful, like that's going to be herpes simplex. If you have gray or yellow exudates and very, very severe lymphadenopathy that may even suppurate or produce pus, that is your cue for Haemophilus ducreyi. And going over to the painless side, if you have shallow ulcers with a clean base, primary syphilis. I like to think of clean base, Treponema pallidum, keep it palatable, clean. I don't know. It's kind of helpful for me, but my last memory hook was absolutely terrible. So we also have beefy red friable ulcers, which can often induce ulcers on the oppositional skin. That would be a big cue for Klebsiella granulomatis, which I was myself not as familiar with, but if you see beefy, red, and friable, you know where to go. And then lastly, an exudative ulcer with painful lymphadenopathy, not a painful ulcer. The lymphadenopathy itself is painful, and potentially even fluctuant adenitis or buboes. That is your cue for Chlamydia trachomatis cerevirus L1 through L3. And these are this is a table from URL. It's just basically summarizing a lot of the same things that I said. And yeah, some other summaries from NBME explanations. So thank you very much for your attention, and if you have any questions, feel free to reach out at my email address.